It's my pleasure now to reintroduce to everybody Dr. Joseph, who is going to and has some information he wants to present. And then I think we'll have time for people who have questions based on our subject. So Dr. Joseph, welcome again. And then the floor is yours.
Well, good morning. And as always, thank you. I think I learn so much from each of these just by listening to individuals around the county. And it always makes me proud to be in this county. I'm going to share my screen, if that's okay, Steve, if we can make that work. Okay, today is going to be a little bit different. I always had the opportunity and the pleasure to address science and things that we were doing in the field of molecular diagnostics and managing patients. And today I decided to go a little different direction. We'll review a little bit about protecting yourself and about what we know regarding the virus, and certainly be available for questions. But what has become clear from when we first started doing this is that this is not going away. There were so many predictions, and predictions are always fraught with problems and guessing, and I don't make predictions. Rather, I try to deal with what we have at hand and projections rather than predictions. But what's clear now is that we have to learn to live with this virus as opposed to waiting for it to go away. We now know that from the activities of the virus, it's very clear we have to change the way we think, the way we act, and what we do. So in the bottom right of this screen, I have put just some highlights of some of the things that we have seen as a memory refresher. You can see what happened on New Year's Eve, and we had our first case in late January, and then what made it on our kitchen table was the Diamond Princess quarantine, because that affected the Northern California area. We received patients from the Diamond Princess into Contra Costa County. And then we had the March 16th stay-at-home order. And that was the big event for all of us. It was the shelter-in-place order. And now we are starting to see that after 2 months, the beginning of the reopening. And the beginning of the reopening doesn't mean that we have controlled the virus. It means that we have tempered the virus. And that's what we're going to talk about today. So a little bit of a review. This is predominantly person-to-person spread. The orders that come down from our health officer really focuses on an infected person gives it to another person. There are an occasional case that occurs from a high-touch area, so disinfecting high-touch surfaces is important. And as I've said before, even if you touch an area that is heavily contaminated with virus because an individual just opened the door before you and had virus on his or her hands, you can't get that unless after touching the doorknob, you touch your face. It won't go through the skin, it won't go through your hands. But those are few. By and large, it's person-to-person spread. And this will be important as to how we plan our activities in the future. You can get it by just having a discussion with someone, as you can see in the upper left. And the biggest problem that all of us face is the way this virus acts with our immune system. And what I mean by that is it's contagious for 2 or 3 days before a person develops symptoms. And some individuals may never develop symptoms. But by and large, the risk here is, let's assume the gentleman on the left does not even know that he is carrying the virus, and he is exposing the person on the right just by having a conversation. And then, of course, what's worse than that is talking loudly, yelling, and sneezing or coughing. And that puts more virus in the air. And we're going to address this a little bit later in one of the questions. But the amount of virus that goes into the air from an infected person determines the contagiousness. Herd immunity is a concept that we have always hoped for and we will hope for. The upper left shows a typical community, and the red dots represent the number of people who are immune, either by vaccination or by recently having disease. And the guideline is 60%, the target is 80%. And as a comparative, we have herd immunity in Contra Costa County against measles, mumps, rubella, chickenpox, smallpox, many viral diseases. And what that means is if someone happens to enter our community and is infected and is contagious, it's unlikely that that's going to cause a problem because the majority of persons are immune. So it won't take off like the coronavirus has taken off. That's our target. Our target is herd immunity, and it's likely that we won't get there until a vaccine is effective. This gives you an idea of where we are in the country. New York, which has been tremendously seriously affected, is only about 20%. London is between 15 and 20%. And as was mentioned by Supervisor Anderson, we're only at about 5%. So we're nowhere near herd immunity, which means that the majority of individuals in our county are susceptible if exposed. Now, let's talk about what has happened. 3 months ago, we saw this virus taking hold and it was running quickly. And the concern was that we could exceed our healthcare capacity. What this meant to the health officials and to the scientists is if so many people got infected, we couldn't handle them. The ICUs would be full, which became one of our indicators. How much room do we have to care for sick people? And if we exceed the healthcare capacity, people die. If we can maintain healthcare capacity, people live. Very simply stated, we can't provide the good care that we know how to if we're overwhelmed. So the solution to that problem was a lockdown. And I use that term because it's emphatic. This was the shelter-in-place order. You put people at home. It is a method that has worked for centuries. You lock them down, you quarantine them, you keep them out of the public. And the curve below, I'm impressed at how many people know what this old epidemiologic term now means, flatten the curve. The red curve means what would have happened if there was no intervention, if we did not do the shelter in place, and we would have exceeded the healthcare system capacity as shown by the dotted line. And I heard Governor Newsom on television the other night on the local news, and he said it so well. We didn't flatten the curve, we smashed it. And everyone needs to take credit for that. Everyone cooperated. The shelter-in-place order, particularly in our county, was so effective that we never exceeded healthcare capacity, which is what has happened in New York, what has happened in certain parts of New Jersey, certainly in London and in Italy. We avoided that by tremendous cooperation of our community. Now, let's focus on the blue curve. The blue curve means that the virus isn't going away. It's actually lasting longer than if we did nothing. The time frame going out to the right means we are going to have to learn to live with this. And we're seeing changes in what we saw for the red curve. What we're now seeing over the past 3 months is a difference in population. So consider this something like a horse race. Those who are in front, the horses that are running the fastest, are still running the fastest. What I mean is they are the ones who are getting infected. They're still in the lead. The nursing home catastrophes that are occurring, the Marine barracks or the Armed Forces barracks, the closed areas where people can almost not avoid spreading this are still in the front runner. But the fastest horse, I mean the one that is making tremendous strides and very quickly heading toward the lead, are the younger people. That is people under the age of 40. They are rocket shipping to the front. That is where the number of new cases are occurring. And that appears to be increasing regularly. The causes are not yet known. As was mentioned earlier, we have tremendous contact tracing, looking at everyone who gets infected. So it's too early to say if it was because of the reopening, if it was because of Memorial Day celebration, going to the beach, the demonstrations, the protesters, the parties that are going on. It's too early to say that, but it's very clear that where we're seeing the spike in the United States, and also in our county, is in the younger individuals. And their social status is different from ours. What's important here, and I can say this as a scientist because I understand it, lockdown works, but lockdown is not sustainable. We have to figure out how to live with this virus as we reopen. Now, this is what goes on behind the scenes. We hear things like outdoor dining is acceptable and indoor dining may be coming, and there may be schools opening. Reopening is done by a lot of effort of deciding what not to do, what is completely unsafe. And it's a balance. And Mayor Clarkson brought this up to me weeks ago, if not a month ago, like, how do we balance this? And there are very, very smart people that have to consider the personal risk of an individual. Let's just say it's someone who is at greater risk of dying because of underlying disease or age. The risk to society. What happens if we have an outbreak in our society, and the workplace risk? Will it close down an essential workplace? Will it close down a fundamental workplace? What does it do to our economy? And all of these go into deciding what we can do and probably what not to do. The important thing here is that we don't go from slammed shut to wide open. Understand and work with the county health officers and the government that this is a graduated situation based on extremely thoughtful decisions. And this is going to be repeated a little bit here. Now, the title of this is Reopening is Not One Size Fits All. So on the left, we talked that the orders are based on personal risks. That is, what is going to be the risk of death of someone with underlying disease in our community, and what is the risk to society? Also, and I didn't mention this earlier, as we reopen, what is the risk of exceeding the capacity of our hospitals and doctors and nursing homes? Because if we exceed it, then we have unnecessary deaths. We also have to focus on maintaining essential services. And what I mean by that is we can't close down an essential service because there is an epidemic in one of those workplaces. And at the same time, it is critically important to maintain economic viability. You know, a scientist will shut the door straight and say, there'll be no infections, we'll just go lockdown forever. And that obviously is not a realistic decision. But I would love everybody to understand that the decisions are made, and the questions that are going to come up because of the decisions reflect multiple sources of expert input. My only input into the decisions have been made is science. I'm a doctor, but all of these other things are way beyond my expertise, and I'm so proud of our health officers and our supervisors who consider everything with all of those particular variables. Now, when I say one size fits all, let's just assume that there is, we're now in a stage where outdoor dining is permitted. Outdoor dining doesn't mean that it's appropriate for everyone. Just because it is said that it's permitted, then we have to decide, well, does that apply to me? And so the focus of my comments today is that you as an individual, or you as a head of a family, or you as a member of a family have to estimate your risk. And your risk will guide what you do, and it'll be different from your neighbors. So because something is open doesn't mean, well, now it's okay to do it. And I'm going to go through a very, very rudimentary risk calculation that we're working on, but for the time constraints that we have today, this will give you an idea, and hopefully you walk away with a concept rather than an absolute. So the first thing is, let's take a look at this scoring exercise, and I decided to make it numerical for ease of understanding, plus the fact I'm more scientifically oriented than fine arts. Let's take a look at a risk if infected. That is, an individual, you, me, Mayor Clarkson, Supervisor Anderson, any of us. What happens if we get infected, or any one of us? Well, how severe will that illness be? Well, if you have an underlying disease, an immunosuppressed state, advanced age, it's going to be bad. If you're 35 years old, otherwise healthy, the likelihood of a severe illness is low. And the likelihood of hospitalization, although not zero, is extremely low. So that's the first thing to consider and give yourself a score. The next component, if I get sick, or if a 30-year-old gets sick, what is the likelihood that that individual can spread that virus to someone else unknowingly? Well, if a 30-year-old lives in a house with a grandparent who is undergoing cancer chemotherapy, that's an extreme risk. If a 30-year-old is living in an apartment with another 30-year-old and is wise about what he or she does and only contacts other individuals of the same age, then that risk, although you can spread it, the consequences of that risk are lower. And perhaps I should change that second line to say the consequences of spreading the virus to others. And then what all of us have to consider if we're in the workforce is, if I get sick, what is my risk of an inability to provide for my family? And anyone who gets sick, even if you're young or healthy, you're going to be out of work for a while. Well, if you're a young person who's home from college, the chances of that affecting the ability to provide for others who are dependents is very low. On the other hand, if you are the breadwinner of your family, and if you get sick and you can't work for 2 weeks, only you can decide how important that is. So this is the first component. I'm going to show you the second one in a moment. But this is a scoring exercise of what is the risk if you as an individual get infected. Now, this is completely different. What is the risk of getting infected? And this is where we have to decide as individuals, in which activities do we participate? And when I say one size fits all, what I mean is what I elect to do and what everybody else elects to do on here, and what everybody who is watching will likely be different. So what is the risk of my getting infected? Well, the first thing is the community incidence. Incidence is the number of new cases a day, or the trend, and it's going up. It's going up in our community. It's going up nationwide, with the exception of some pockets, but basically there's more virus out there to which I could be exposed. And the prevalence, that is how many people in our area are sick. And that also is going up. So there was a time when the testing was 2% positive, and now even though we're doing more tests per day, the percentage of those who are carrying the virus is increasing. So it's on its way up, and more people are sick out there in the community. So think about that. This is, what is my risk of getting infected? And then my daily activity. Does my daily activity actually negate all of that? In other words, if my daily activity is working from home, and let's assume that I'm an accountant or a stockbroker or investment advisor, and I never leave my house, well, the community incidence and the community prevalence won't calculate into my risk of getting infected. But if I'm an individual who is in the workforce or is out in our community, then my daily activity will put me at a particular risk. And only you can determine what that is based on the number of people that you come in contact with. So remember, we started off by saying this is a person-to-person virus. So your daily activity, that is how many people that you come into contact with, is part of determining your risk of getting exposed or infected. And then there's been this concept of a social bubble, exposure bubble, family bubble. And let me give you an example that I hear most commonly. I live on a particular street, but I live in a different house from my kids. And they are in my bubble. I want to see my kids. So I go to their house and they come to mine. Okay, that is your exposure bubble. Well, if your exposure bubble is very small, very limited, very controlled, then that's a very low risk. But if your exposure bubble includes a family that may have a 25-year-old child or several in that age group, and they're going to parties, well, your exposure bubble risk now has changed substantially because they can give the virus to someone in your bubble, and then that can be expressed to you. So these are all individual things. Now, the individual risk of getting infected, and here's where the variability occurs from me, how I differ from you, and how you differ from your neighbors. Once I understand my risk, and once I understand the community risk based on the first three, then we decide what we do. So let's pick an event. Is it safe for me to go outdoor dining? We know it's permitted, but is the risk too high for me, or is the risk acceptable? Everything that is opening, everything that we are now permitted to do is not risk-free. There is a risk with everything. There's a risk, but the risk may be low. So will I go to outdoor dining? Will I choose to go to indoor dining, shopping, retail? Am I going to go on a weekend trip with another family camping or to another town or to Tahoe? What about sporting events if they open up? Is that risk acceptable for me based on my individual circumstances? And air travel is opening up. And then, of course, you see this keeps getting increasing and increasing with concerts, large events, protest marches, and things like that. So the concept here is individuality. Understand your risk based on your activity, your bubble, and then decide what are you going to do today and what are you going to do with an invitation. And permitted does not mean without risk. Our county officials, government and health, have to decide what is permitted, but they're never saying that this is without risk. Only you can decide if something that is now permitted, is it for me? And that's the topic of what I wanted to get across today. This is an individual decision. We absolutely have to reopen. Lockdown is not sustainable, but don't consider what's open is okay for you. Feel free to make your personal decisions based on your own analysis of you, your family, and the likelihood of maybe spreading this without symptoms to someone who could have severe disease. So to emphasize, still, the way we prevent this virus from spreading is the hands, face, mask, space. Wash your hands or use hand sanitizer, and I often say wash your hands as if you've just changed a baby's poop diaper. Seconds don't work, singing songs don't work. Just think about what might be on your hands and wash them that thoroughly. Hand sanitizer, as long as it's 60% alcohol, is excellent. I think the dangerous products with wood alcohol have been removed from the market. Don't ever put wood alcohol on your hands. Keep your hands away from your face. If you don't touch your face, what's on your hands makes no difference until you wash them. You can get rid of it. Masks work. Masks save lives. Masks are not going away. Remember, masks protect you from someone else. You can be very, very conscientious and never walk out of your house without a mask. But if you get onto a subway, as it looks like that individual is doing, and everybody around you is not wearing a mask, you're at risk. So you're wearing a mask is a way to be socially conscious. And then, of course, socially distancing, has been proven, it has been studied, it works. This virus will fall to the ground. It will not be spread from person to person if you stay away from each other. And so the last slide is this. Our future is uncertain. I ask you, don't try to listen to people who predict. This is like trying to predict what a shark is going to do. You can model, you can get some ideas, but it's better to prepare than predict. And I could give you tongue-in-cheek numerous predictions that have occurred over the past 3 months that have been so far off base, it's a lesson learned. The lesson learned is when someone tells you, well, this is what's going to happen, then be skeptical. They may be right, they may be wrong, but it's a roll of the dice. I've heard the term many times, and I think most of us understand it, that there's going to be another wave. Well, a better analogy is not a wave, but perhaps a fire, perhaps a forest fire or a brush fire. When you can suppress it, but when you back off, it flares up. You can suppress it, and that will go on and on and on until we reach either therapy or herd immunity. So be cautious of people who think they know what's going to happen next month, but be prepared for what could happen next month. And so with that, I will stop. I thank you again for inviting me. It's always a pleasure. This is a different concept for today, so we'll see how it goes.
Another question, and I'll try to summarize this one as best as possible. The Contra Costa County Health and the County Office of Education just recently released guidelines on Monday that have social distancing requirement proposals between 4 and 6 feet, wearing masks for students, creating cohorts of the same group of students to stay together, and various other options. So what is the safety, how shall I phrase this? I'm trying to find out.
The rationale for
the rationale, and also the risk involved with the difference between 4 and 6 feet and having the same cohort of students sitting together and also facing the same direction. So what are the safety risks involved with that?
Well, and a lot of it just comes down to science. Obviously, if you have the same cohort of students, you're not mixing and matching the germs that may be passed from one family to another. So that's a great factor. Originally we were saying 6 feet apart. We recognize you need to get more students in a classroom to be able to have that, the ability to teach, the ability for teachers to not have to have 2 or 3 or 4 sessions. And so 4 to 6 feet, I believe, just seemed like a reasonable number. Certainly, we're seeing in our children's camps, you can be a little bit closer as well. But again, on a regular basis for a school year, I think they felt that was a comfortable number. If you're all facing in the same direction, you're less likely to be spraying in each other's faces. I mean, that's, a lot of it is just sort of a common sense approach with what we know today. And as Dr. Joseph has pointed out, we don't know everything. There's so much about this disease, this virus we don't understand, but based on the science we have today, these seemed like reasonable ideas of how can we keep our children in school, safe, having this positive learning environment, and keep the teachers safe as well.
I think for Dr. Joseph, I think a lot of our educational leaders are struggling with this issue. And they're struggling with trying to create a learning environment and the constraints they have and keep their children safe. And I think they're looking for some direction. Not that you have all the answers always, although I think you have great answers. But in some ways, educators are looking and leaders are looking to the scientists. Is that appear to be safe? I think that was the essence of the question that might have been asked.
A very good question. So let's start off from the decision that was made and then go to maybe some science behind it. Every decision that is made like that is not made whimsically. It's made with input of a lot of different people. Certainly what is necessary for education, what is available in the physical environment of the school, and then what is thought to be safe from the scientific approach. And those decisions that have been made, we have to understand that they're made with a lot of thought, but they're not made without the plan of follow-up. So because we have such tremendous contact tracing, if this doesn't work, it will be identified. But we have to believe that decisions that are made with a great deal of thought. Now, the science behind it is, it's a little bit of memory, but it goes like this. 6 feet apart without a mask and normal talking is safe. Okay, that's just the fact. The reason we wear a mask is because the two people that are 6 feet apart, one of them may unintentionally or unexpectedly cough or sneeze. So it's a little bit of belt and suspenders, and it's easy, it's safe. Now that's face-to-face discussion, face-to-face coughing, face-to-face sneezing. Without a mask, 6 feet, the virus will fall to the ground and not be infectious. With a mask, it even protects if a person inadvertently coughs or something as simple as clearing their throat. Just something like that actually produces a lot more virus, but it's face-to-face. The concept here is that the risk is proven to be lower if everyone is facing the same direction, because you don't get this virus into your face if someone is breathing behind you. So there is the safety factor of facing the same direction, the safety factor of the distance, the safety factor of the mask. All of this goes into what I think sounds like a very reasonable decision, but not one that is going to go without follow-up.
Thank you, sir.
Great. Another question is, someone is reporting that they're hearing of up to 55% of tests are false negatives. So I don't know if we have any statistics on the false negatives, but as an example, they said that one of their employees received a negative result, but all 5 people in the household tested positive. How soon should this person be retested? How realistic is it that that person is actually negative, and could that person be a carrier?
I would definitely suggest they get retested. We asked Dr. Joseph. The test we're doing in the county has a very, very small percentage of false positives or false negatives. If it's an antibody testing, those are much more unreliable. But the testing we're doing with the nasal swab is, I want to say it's 0.3%, but I could be making that up. Dr. Joseph, what is your experience with the nasal swabs that we're doing? I'm hearing it's a very, very low percentage.
Yeah, false negative needs a definition.
Yep.
A false negative in laboratory science means that it was actually positive, but it was missed. That's unlikely. What is more likely is when a person has a negative test and later turns positive, is the test was done too early to detect the amount of virus that the laboratory method is designed. So for example, if I am exposed today and you do a nasal test on me every day, it is likely that the first 3 to 4 days will be negative. But after that, it will start to turn positive. So a false negative needs to be explained. A negative test in a person who is contagious is extremely unlikely.
Mm-hmm.
That would be a true false negative. That would mean that I'm shedding virus, but the test missed it. What is more likely is that I am not yet shedding enough virus to be contagious. And that's because the tests that we're talking about, the PCR test, is a very, very good test. Each of us, if everyone in my family gets infected, each of us will turn positive on a different day. So for the individual that you're speaking of, where his entire family was positive and he was not, he might be an individual who doesn't get infected, or he might later turn positive. And as mentioned, continue retesting if it is likely that a person has been exposed.